is here. Well, good afternoon, everyone. All right, good afternoon. All right. First, let me thank Huda Zogby. She's put together a wonderful meeting and the 3 sessions that covered social, well, first of all, Surgeon General Vivek Murthy. Wasn't he terrific? Yeah. And such compassion and sincerity, and really gave a human touch to this whole issue. We were followed by discussion of social drivers, and then technology and science, or the emerging advances in the last panel, which is terrific, on care delivery. So I think we recognize this is a big problem. I mean, the stat says 1 in 4 or 5 of Americans experience mental health challenges throughout their life, sometime in their life. So that means sitting here, I can see many of us can resonate with this, right? So it's a really big unmet need. And when you think about the whole scope of things, and as you covered today, I feel that we really need to have a group to talk about what are the problems, what are the solutions, right? And how do we move forward? And that's what I put together the President's panel. So this forum we started 10 years ago. Every single meeting, the theme which we discuss, we want to have an expert panel, leading panel, to help us wrap this all up to say where do we need to go and what's in the future. So in that regard, we have 6 outstanding panelists who's going to tell us about what they do and what are the kind of challenges and where's the solution. So if I may first introduce the panelists. On the extreme left is, or your right, is Daniel Gillison Jr., CEO of the National Alliance of Mental Illness. We have lived experience patients that join us to tell us what the issues are that they face. We have Garland, Professor Emerita of the University of California, San Diego. You hear that she's really someone who's got the clinical experience and also issues of workforce. We're very lucky to have Anita Everett, Director of the Center for Mental Health Services within SAMHSA, Substance Use, Abuse, and Mental Health Service Administration. And thank you very much for being here, Anita. And then we have Representative Don Beyer Jr. from the 8th District of Virginia, who co-chairs the Congressional Mental Health Caucus. Thank you, sir, for being here. And of course, we have our friend, Kathleen Sebelius, the Honorable, who was the former governor of the state of Kansas and former secretary of HHS. Welcome. And last but not least, Ranga Krishnan, who serves as chairman of the National Research Council Singapore and former CEO of Rush Medical Center and former dean at Duke University. So what I'm going to do is do 3 rounds of discussion. First round, I'm going to ask every one of our panelists a question, but give them about 3 to 5 minutes to talk about their own point of view, their experience, to tee up the issue. Second round, I'm going to ask more general questions about how do we fix this problem. Then I want to end the third round with Secretary Sebelius and also Ranga talk about what are the big ideas going in the future. So Daniel, let me start with you first. You know, we are so glad you can be here because the voice of the patients, the voice of the experience is so important in telling us what, in fact, are the challenges. So we heard a lot of issues about social drivers, and boy, that session on technology and innovation is really exciting. But then, as Richard Frank said to me, I saw a Michelin-star restaurant, but now how do you really give it to everybody? What's needed, right? So I think the third one is what we try to talk about, what needs to be done, and there we are. Tell us about your experience and what your organization does, and really what are the challenges facing patients.
Well, first of all, thank you very much to you, Dr. Dzau, for making this your presidential forum topic, and to the National Academy of Medicine. And to every one of you all that have chosen the discipline that you're in, you have a why. And that is who NAMI is. Everyone that does the work for NAMI has a why. Now, who is NAMI, the National Alliance on Mental Illness? We are the largest grassroots mental health organization in the United States. Like the National Academy of Medicine, which is 54 years young, we're 45 years young. We were started in Madison, Wisconsin, by a group of mothers sitting around a kitchen table that decided to advocate for their sons who had just been diagnosed with a serious mental illness. So we advocate, we educate, we listen, we lead, and we learn. And we support. And we are the largest grassroots mental health organization in over 650 communities across the country. And as our U.S. Surgeon General ended his presentation with love, our work is about love. What love has to do with our work is that every one of the people that does the work for us with lived experience, it is about love. It is about turning their pain into purpose, and that purpose has become their passion. Of the 650 organizations across the United States, we provide support groups and free programming to communities. We like to say we're the DNA in the communities. So when you talk about the end point, which was the justice system, all the way back up to the front end with early intervention, NAMI interacts with that in terms of support services and trying to move the equation forward. We're also very involved in looking at what happens in communities across the country, as we know that there's, in last year or so, it's been over 49,000 deaths by suicide. That's over 163 a day. I want to congratulate and thank Congressman Beyer for his work on suicide prevention and the legislation on that. And we're very front end on that body of work as well. We also know that, to the point, 1 in 5 live with mental illness, but we also know that 1 in 2 will experience some type of a mental health condition during their lifetime. Dr. Murphy talked about the study that just recently completed on anxiety for parents. I think it's at 48.1% or something. So that's that 1 in 2. So we are very vested in our body of work and trying to do things to address that. As you look at our work, and it's always difficult to go first because you're looking at your colleagues and you're like, you don't want to take more time than what you have.
That's all right.
So hopefully I'm staying within my time frame. We do work in, we also heard in some of the presentations about the faith-based community. Faith-based is important because as you think about first responders, in many communities, the trusted person, that first responder, is that faith-based leader. Be there an imam, be there a rabbi, a Baptist minister, Episcopalian priest. It doesn't matter. They are looked at as the trusted voice. So families go there first to see what is my family navigating and what should I do about it. We also know that about 50% of the United States, in terms of folks living with mental illness, will actually get care. In communities of color, it's about 33%. So when you say that, let's invert that number. 66% won't get care. And what does that look like? And how do we change that narrative? So that's a body of work that we're involved in. So we're involved with faith-based communities. We're involved on the front end in terms of early intervention. And if I can speak to that for a second, youth and young adults. If we look at our demographic right here, we know that we've got to get more youth involved in mental health. And Dr. Garland will be speaking to that, I believe. But as we do that, how do we demystify mental health and get more young people involved in it? So what NAMI has done is we've created a next-gen group, next generation of advocates and leaders. And they are a cohort of 10 young adults that work with us on an annual basis to form and frame our work going forward. The other thing that we've done is we have a youth and young adult council that actually works with us to do some additional work to move the needle forward in terms of what are they seeing? What is it that they hear, and how can we go upstream and get services sooner for them? So that's a bit about our work and who we are. And the other part of it is that in these 650 communities, many of the leaders that are doing that, the executive directors, are volunteers. And when I say that, I just wanted to resonate. It's their pain that they've turned into purpose, and they are doing the work every day to try and move the needle to make sure that people in the communities that are living with mental illness get services. So they know where the services are, they know how to connect the dots, and they actually are doing that work for them. And our youth and young adults are also involved in that as well. So that's who NAMI is, and that's what we're doing, and we're trying to do it in a very intentional way so that we can execute where we need to move this needle.
Thank you. So I thank you for what you do. This is so important, particularly having the voices, giving patients voices and being able to help the best you can organize this. But I happen to know, I talked this morning about a fragmented healthcare system. I happen to know that mental health is facing tons of challenges, right? And so what I'd like maybe, Anne, you are a clinical psychologist. You've been in the front line. You work with schools and you work directly with patients, right? And so you have the whole spectrum. So the way I look at it is that it's been really a challenge to get access, to get quality of care. We don't have enough in the workforce. And people say, well, a psychologist, psychiatrist. But in fact, has been said all day, you need lots of others, community health workers, you name it. Talk a little bit about what you do and how you see the challenge we face.
Yes, well, first, thank you so much for inviting me, and it's an honor to be part of this panel. And in addition to being a practicing clinical psychologist, I've been leading training programs for providers across different disciplines, so psychology, counseling, marital and family therapy specifically. So I'm here to talk primarily about our workforce challenges, and we do face a very significant workforce shortage. And that workforce shortage contributes, of course, to the unmet need and the difficulties with access that we hear so much about. Our workforce is aging, that's another problem, and it's geographically skewed. By one estimate, 70% of counties don't have a single child and adolescent psychiatrist, for example. That's quite startling. 70% of counties in the United States. As you just said, we know that physicians represent just a tiny fraction of the behavioral health workforce. In fact, psychologists represent a pretty small fraction of the workforce. The workforce, the frontline workforce, consists primarily of master's level trained social workers, counselors, marital and family therapists, and those with a bachelor's degree, mental health workers, or what they're different names, community health workers, mental health workers, and increasingly, as we've heard, community health workers, peer support workers, paraprofessionals. So we have this vast workforce at different levels of training in different disciplines, and we really need to expand and diversify across all those disciplines, across all those levels of education. I think we need to do a much better job, and this came up in a slightly different but related way in the previous panel. Dr. Frank talked about matching or need to service delivery, and we need to think about that with our workforce as well, with our workforce resources. We need better, I'll use the word triaging as a non-physician. I don't know how appropriate it is to use that word, but we need to do a much better job of figuring out how we can utilize the resources we have at the level of workforce training and expertise. We know, for example, that we have increasing evidence that peer support workers, family support workers, paraprofessionals can do an absolutely excellent job at encouraging engagement, which is essential. Engagement in services is one of the biggest barriers. So initial engagement and continued engagement and participation. And we need to make sure we're utilizing those workers appropriately for that. That's distinct from treatment for severe mental illness, but we need to, that's what I mean by triaging and matching expertise to actual workforce skills, workforce training. We need to recruit and retain a new, and I would say somewhat different workforce. By that I mean, we have, and I'm going to speak primarily about the frontline workers. We'll leave psychiatry and psychology aside for a second and talk about the vast majority of people on the front lines doing the work in community-based clinics, for example, where most patients are seen. People usually go into those fields, they're motivated by compassion and empathy, they're good listeners. I know this because I've spent decades reading their application essays for graduate school. They rarely mention excitement about scientific discoveries, about the use of digital technologies and AI and neuroscience. And we need to reach out to a new potential workforce, get them in the pipeline, students who are interested in STEM and its applications to mental health, who are interested in climate change's intersection with mental health, and the use of AI, et cetera, et cetera. I feel that I'm going to talk more about this in later rounds, but we need to expand the vision of what a career in mental health could be and inspire people who wouldn't necessarily have considered a career in mental health before. So that's one of my goals.
Thank you. Anita, you play such an important role because SAMHSA is a government federal agency that help us address many issues that's been talked about. So can you tell everybody a little bit about what are your high priorities?
Yep, so thank you, and thank you again also for selecting this as a problem for you to focus on, because it's important, very timely right now. So yes, I'm Anita Everett. I am a community psychiatrist. I have a long-standing history of working in those spaces. I currently work as the director of the Center for Mental Health Services within SAMHSA. SAMHSA is the lead federal agency that's dedicated strictly to mental health and substance use disorder services. In that way, we use strategies that are common to public health as well as services delivery to affect what we do. Some examples of the kinds of ways we do our work are a series of services grants, which include funding to state mental health authorities, as well as a series of discretionary grants, which are on a variety of topics that range in age from early childhood, school-based mental health, K through 12 school-based mental health, and a whole other range of services that typically start actually with Congress, as I'm sure Congressman Beyer knows, having a problem that they want to identify, and so they will allocate to us a certain amount of funding to address that problem. The other ways that we do our work, two other ways I want to just mention briefly, are products that we create, and one example of a recent product we've created was through an arrangement that we have with the National Academy here that looked at what we can do, what we as a nation could do. Can you make recommendations to us for expanding the number of providers that participate in public payer sources? So that's not going to solve the whole problem of the workforce shortage, but it's a part of the problem, how we can get more the full range of providers to function and accept payment from Medicaid, Medicare, and the Marketplace program. That came out just in the last month ago. We also do, in the spirit of Public Health 3.0, which is actually part of the public health focus that was present during Secretary Sebelius' time with us. Public Health 3.0 has many different strategies that were intended to sort of highlight and raise up the level and attention to public health itself as an important entity in advancing America's health at large. One of the take-homes from that, or one of the ways that we work with that, is a series of convenings that we do. And one of the ways that manifests itself for us is policy academies, which include gathering groupings of people who are expert in certain areas together, typically with teams from states or communities that want to address certain things. An example of that we've done recently over the last couple of years is focusing on the rising concerns that we have about Black youth suicide, which heretofore was a fairly stable number and now has been rising. So that's an example of the kind of problem that we convene folks around to addressing. So those are some of the ways that we do our work. We were up-funded quite a bit during the COVID era. A lot of our programs got some extra funding, and so I think that does reflect our nation's concern and attention to recognition of mental health as a concern nationally, particularly among youth. Some of the problems that I see, or sort of that we are thinking about at SAMHSA, three in nature that I want to talk just a teeny bit about. One is the problem of pervasive stigma. And so we, although that's not a new term, it's sort of old, some people even describe it as passé, been there, done that. We're very aware that stigma is an extreme problem, and it still is a barrier. When you look at the information that Dr. Frank presented earlier from our National Survey on Drug Use and Health, you get the next layer in, you see that one of the main reasons that a lot of people don't seek treatment who are in need of treatment is stigma, self-stigma and or structural stigma that they might experience in the workplace, and or social stigma that they might experience in their tribe or in their families, among their cousins or family members. So stigma is a big problem. One of the significant ways that we look at stigma at SAMHSA is to really have a strong emphasis on the presence of people who are living well in recovery. We think that's really important to have it known and out and about. So that is an important sort of aspect of what we do and one of the ways that we highlight that problem of stigma. The second problem, I think, is the people and matching people. I think we've mentioned that, but I resonated quite a bit with the concept of matching people to what they need when they need it. And we still do not have a good system, I would say, in the United States for that matching at the time of need and during a time of maintenance or during a time of when things are fairly stable in people's lives. We know these mental illnesses typically have flare-up periods and then also long periods of stability when things are going well for a person. And then the third thing I want to just sort of say, just sort of a bucket list of problems, is lack of a common vision for what things should look like. We've had a history over the last 200, I sort of date us back to 200 years in the public mental health system, or mental health services systems in America itself, of incrementalism. We had big sweeps of things that happened years ago when we deinstitutionalized people, but we've not really had since then a common vision. And so the term of fragmentation, I really resonate considerably with that. That was first sort of used in giant public parlance during the New Freedom Commission report, which reported one of its main outcomes was the fragmentation that had happened. One of the ways I think about that is if you have a person with schizophrenia, one of us had a brother or sibling with schizophrenia, and you live in one community, you have no guarantee that when you move to a different community that you're going to get the same range of services that you had, both for the entryway into the clinic or whatever services you need, as well as the recovery support services, the social determinant related things like housing, supported employment, those kinds of things. So a common vision is something that we have not really had as a vision. I would assert the last time we had a common vision, in my mind, was in 1963 with the Community Mental Health Center Services Act, which spelled out a vision for a community-based system. I believe right now, and I'll talk a little bit about it later when we get back around to it, I believe we have two things that are poised to reinforce the concept of a national vision. Both of those are things that Dr. Sullivan mentioned earlier today. One is the CCBHC model, which I think creates a common vision for what a person with a full range of mental illnesses and all age groups is living with mental illness, what they could access. It has access requirements when you're in the system, what you are supposed to have access to, and then recovery support services that address those longer term things. So CCBHCs, I believe, are a game changer. The other one is the 988 and related crisis services system. So there is 988, Dr. Sullivan mentioned that gives us anywhere in the United States for the last 2 years a call line that's available. I believe that's a game changer and going to be a game changer in the future. It also has related services, and the way we frame that is across 3 services. One is, what does a person in crisis need? Starting with the person. The person needs someone to talk to or someone to respond, preferably who's not law enforcement, to a situation that's urgent in a community setting. And then third would be a place to go. So anyone can go to an emergency room, like when you call 911. We prefer for individuals to be able to have access to a place we call them community crisis receiving centers. As a result of the set-aside in the block grant, which we distributed to all states and territories, we've seen tremendous growth in I call those related crisis services from our nation. And I believe those have a good shot at being a game changer. So there's a common vision, and we get beyond just incremental, this state or this county's doing this year, and we move forward with a common vision so we can get people what they need when they need it.
Thank you. I think you get an idea why I have these great people up here. We really talk about underground experience on workforce issues, and then, of course, lived experience. Great SAMHSA agencies trying to look at how to drive changes, right, in the community. And now, of course, we're so glad that you're here, Representative. And, Don Beyer is he co-chairs the Congressional Mental Health Caucus. And talk about 988. He actually secured funding for 988, but also help us pass the peer-to-peer, right? It's called Mental Health Support Act. So we want to kind of get from you, it's great to have a friend in Congress or other friends. How do you see, in fact, Congress and Washington being able to help address this issue?
Well, first, thank you so much for inviting me to be part of this. I'm very humbled, surrounded by mental health professionals and the Secretary of HHS at one time. To let Slum from Congress come on, this is very nice of you. and I wish I could say that I was optimistic about the funding, which is the primary thing we do, but let me retreat instead to things I'm deeply interested in. And this first is suicide prevention. Back in 2015, we were having a sit-in in the House protesting the absence of gun safety measures. And the Secretary may remember that. And it was my turn to speak at 4:30 in the morning. Everything had been said. And so I thought, well, people were reciting the names of people who had been killed in recent gun shootings. So I thought a meaningful thing would be to recite the names of people I'd known who had died by suicide. At about the 7th name out of the 37 I had, people were fleeing the House floor. And I realized once again the incredible stigma about talking about something that takes the lives of almost 50,000 people a year and is moving in the wrong direction. Wrong direction at every age category. And so I've tried to make a centerpiece of the contribution I can make on the Hill, working with NAMI, with the suicidology groups, with suicide prevention, every idea we can find that will try to make a difference on this. My youngest is a gun violence prevention analyst at the Brady campaign. She proudly says she's the only one who knows who talks about suicide all day long without being depressed, because that's 2/3 of all gun deaths. We worry about assault weapons and school shootings, and those are very meaningful and tragic, but that's 2%. The 67% is the suicide that we don't talk about. So talking about stigma is so important that we get rid of that. You see it even in the newspapers. They won't tell you why people died because you know that it's a suicide and that people don't want to talk about it. So, and I know later we'll talk about solutions, but I think that's a very important place to go. The second big thing that really concerns me is the epidemic of anxiety and depression and suicide ideation among young people. It's written about all the time, many causes, from the COVID crisis to the flux in the world to social media. I don't know about causes. I do know that we're sorely poorly equipped to deal with it. You talked about the shortage of healthcare professionals. Every time we'll have groups of high school counselors and college counselors coming in begging for help, that they have 800 to 1, 1,200 to 1 type ratios, that they're dramatically understaffed. The SAMHSA or CDC was in 2021, 22% of high school kids had thought about dying by suicide. That in that same survey, 60% of high school girls said they had periods of intense hopelessness and despair, and that 25% had actually made a suicide plan. There's lots of things that we can do, but we're not doing them yet. And the third thing, which is just talking about stigma, my oldest got hit with schizophrenia now 30 years ago. One of the things I've just seen is how incredibly broken our system is for those that are truly sick. I stay close to my 4 sheriffs across the river. Arlington County, their jail population has been down a lot. We have very little serious crime. 2/3 of our inmates are there with serious mental illness. 2/3. Fuller Torrey famously says 600,000 schizophrenics in jails and prisons, 600,000 living on the street. I parked next to a park 2 blocks away from here. And the park's all fenced off. The last time I was there was with the gate patrol with the Salvation Army back in Christmas, delivering meals every single night. The DC's cleared them all out. I guarantee you almost everyone has a mental health crisis. My son, to be personal again, he's been evicted from virtually every hotel, motel in Northern Virginia. I can't rent an apartment for him anymore because every apartment has thrown him out. You go to the state and say, what do you have in terms of institutional care? And they say, only for so-called forensic patients. Unless he's killed somebody or is violent, we have no room for him, and it's overcrowded, and it's a nightmare anyway. You probably saw the Washington Post story on the Maryland version this last couple of days. Or we can go to private pay for only $20,000 a month, but you walk away. So he'll be there for a day and then walk away. So as a society, we're not even close to dealing with the millions of people with serious organic mental illness, and we don't know what to do with them. By the way, it doesn't help at all every time he gets hospitalized that there's then a court-appointed attorney whose primary goal is to make sure that he is as free as quickly as possible. And they will make sure that he goes voluntarily so that we can't never make the case to the judge about why he should have a longer hospitalization. I'm sorry to be personal about it, but if we're talking mental health, this is a major issue and we're not addressing it. And with that, I yield back.
Thank you very much. So part of the reason that we have you and others here is to think about solutions. So we're counting on you to help us on the Hill. But Secretary Sebelius, I mean, you were governor of the state of Kansas. You work as Secretary of HHS, Obama administration, passing the ACA. And if you look at your extensive experience from state to federal and looking at the ACA, just give us an idea how we achieve that balance between the levels of decision-making, policy-making, and legislation that can help us get there.
Well, first of all, thank you, Dr. Dzau, for making this the President's Forum, and thank you to all of you for doing the frontline work every day. I have to give a shout out to some HHS folks present, some great leaders, some alums like myself, because spectacular work is being done each and every day. I'm going to talk about a little bit of that state to federal experience, but mention some things that you didn't mention. So I was in the state legislature in the late 80s in Kansas, and like state legislators all over the country, we had a mental health reform movement led by a governor at that time whose goal was to shut down the major state institutions and create spaces for people to be in the least restrictive environment. That was seen as the advancement and the way that was really important for states to go. And Kansas, like many states, passed laws, passed bills. The whole idea was the money would follow the patient. Well, that second part never happened, right? The state institutions were all closed down. That was chapter 1. Chapter 2 was then hospitals and others who were running emergency care facilities. You could at least, particularly parents who had a child in crisis, could find an emergency department with a mental health bed. Those are all gone. So I think we, in that course of time from the mid to late 80s until today, had a series of what were supposed to be reforms that are miserable failures. And so people are living under bridges and in, jails and various places that really the core issue is serious mental illness or temporary crisis that could be solved if there was appropriate intervention. And I think in some ways to deal with today, we really have to deal with that arc that has not been a great arc in America. Secondly, I think, while COVID certainly exaggerated some of the trends that the Congressman has talked about, youth and children's mental health, where the trends were going in the wrong direction well before COVID. COVID just sort of supercharged it and accelerated what was already in place. But I think what we still haven't dealt with very accurately and emotionally is the trauma that came from COVID itself, and particularly the trauma on children. When we talk about 1 million deaths, those are caregivers, grandmothers, neighbors, friends that children lost. They didn't have an opportunity to say goodbye. They didn't have an opportunity to grieve. They didn't have an opportunity, and often created even more instability in lives. And I think we're going to be a good generation dealing with some of that, but I don't hear a lot of conversation about that or really an attempt to address that additional stress. Clearly, equity is a key factor in all of this. And I'm struck by the fact that a lot of the conversation, whether it's, Anne or the NAMI folks who do incredible work on the ground, or what SAMHSA is doing, the language is really very similar to physical health conditions. I mean, we know that those in the least resourced areas have the most likelihood to be affected with social drivers on health. We know that low-income folks have less access to physical health providers. The same is exactly true with mental health, and it may be even accelerated, and the fact that folks in those neighborhoods are often at higher risk. They're subject to more trauma. They're subject to more violence, gun violence, suicide, whatever, that I think we have to deal with. But another part of my life, Dr. Dzau, which I don't know, I'm old enough, I've had many, many chapters. I was an insurance commissioner for 8 years. And I got to tell you, we have to call out insurance commissioners around the country to enforce the law. Parity is the law. It has been the law since 2008. The federal government does not enforce insurance laws. It is at the state level. Every state has an insurance commissioner. That's where the law is. If they are not enforcing the law, they should be sued by the Attorney General or a citizens group or others. Now, parity was passed in 2008. It was updated in 2020. There are new rules that have been put together in 2023 that are able to be viewed, and they're supposed to be implemented in 2025. I would tell you that is a starting gun. 2025, which is just around the corner, those new rules, if they are not put in place, you need to go after insurance commissioners in every state in this country. There is an association that many of you should be familiar with if you're not, the National Association of Insurance Commissioners. They meet 4 times a year. It's every commissioner in the country. And they need to get a whole lot more attention than they have gotten, because it is simply immoral and illegal that the parity law is not enforced. And that's the group who is charged with enforcement of insurance. And if an insurance company is not following the law, they can pull their license. They have the authority to do that. The federal government does not. The insurance, if they don't have adequate networks in a state, the insurance company's license can be pulled. So it's a group that has been under the radar screen on parity for a long time. But I got to tell you, a big spotlight has to shine on them. And with the new rules that are supposed to come into effect in January 2025, it's a great time to bring them to task. We've already talked about workforce, but I just look forward to the rest of the discussions. But I think there are lots of things that the federal government can drive to the state level and that the state has to be responsible for, and one of them is the parity law.
Thank you very much. So Ranga, you're a psychiatrist. You ran a psychiatry service. You ran a medical center. You've been involved with, I would say, so many different ways about mental health and well-being. You are a scientist. So I think as I listen to all this stuff, I hear perspective from patients, from providers, from government. Give us a little kind of perspective how you would want to see that. What are the challenges, and how you would see as somebody who has to run a service and run programs to make it work?
So maybe I'll take this as a chance to say I actually had a chance to work from one side all the way to the other side in more than one location. So when you're hands-on and you're responsible and accountable, it makes you think very, very differently. It's different from a theoretical construct. So I started off working in a state hospital and community health centers at a time when state hospitals were still funded. It changed. Community health centers were funded, but never properly funded, and they always struggled. And then I was in an academic place, and I was more interested in both the clinical side and the research side. We could fund the research well with NIH, and we did well, but the clinical side was always a struggle. And the struggle had to do with payment systems. The struggle had to do with the fact that mental health is not really in tune to just having services paid for piecemeal, which is a transaction-based system, which is our entire healthcare system as it currently stands, a majority of it. It is changing. That plays a big impediment in actually implementing it. Because you're trying to figure out, how do I bill? How do I collect? Who can I see? Who can I not see? How many of this group of patients can be in my system? Which insurance will pay me? Which won't pay me? And by the way, it's an infinite number of sub-plans inside an insurance company. So we would spend 25 cents on the dollar to 35 cents on the dollar just getting your insurance. So literally, it made more sense to do it for free because it did not make much sense to economically run that. That's something I learned on the service side when I was back at Duke. So we partnered with the state system, which I knew, and we could figure out ways to contractually deliver services which worked. So think of all these as we're trying to solve problems we created. It wasn't like solving upfront. Okay, we deinstitutionalized. We said we'll do X, we didn't do X. What is the net result? We got what we said we wouldn't pay for. That's exactly what happened, and it stayed. This is almost 50 years since that movement started in the 60s, 70s, and then, so that's been one issue that there's another perspective which we really didn't have. I'm going to just go a little bit divergent periodically, and I'll come back to Dr. Frank's presentation because I think you were coming in on some clear issues that we have to deal with as a society. The statistics are grim. We don't hear the stories as much. It's only when you hear the stories that it resonates. Statistics and big numbers, they fade. That's now our human brains are designed not to focus so much on numbers. Big number, yes, it's a big number. It is when story is visually seen, it resonates really, really well. A single story resonates a lot more than these numbers. Now, one of the things that I think we touched on, and I don't remember all the names of the presenters, it's also part jet lag, but I would say one of the things that you have to really don't talk about, but we have to, is what's happened in the last 15 years. What's happened in the last 15 years is every one of us has this device in our hand. We cannot live without it. We spend more time on it than talking to anybody in the world. We look at it even when we don't have to look at it. We feel like if it doesn't give us something new, something is wrong. So we're in that stage where we have now adapted to a system that has changed how we think. We are, our collective thinking and our collective behavior has changed. Those systems, I would call the attention economy. By the way, it's not a new term. Herbert Simon, nearly 40, 50 years ago, talked about it. It's the most important part of our daily life. It consumes most of our time, most of our attention, which means most of our money, which means it is about engagement. Why does it get us engaged? Because it's personalizing your engagement every single second. We don't do it. You want patients to come back and see you regularly? It's hard work. the attrition rate for patients is very high. So something to keep in mind is engagement is key. And those companies that run the attention economy know how to engage you. And without that, we are continuously going to have a problem. The last piece that I want to say is we have made enormous advances in trying to figure out how the brain works. We've made enormous understanding of the social factors that play a role in this. We also have experimentally done, in certain circumstances, things that work. But what we haven't done is we haven't pulled it together. We have optimized individual elements really, really well. If you're in insurance, you have to optimize your payout properly because that's what you're incentivized as. If you're a provider system, you're wanting to make sure you don't go under. You've got to balance all your books. If you're a provider, you're under a lot of stress trying to manage the volume of patients you have to see, the amount of records you have to keep, everything else. All that's happened is everything has increased, but the workload has increased. Your productivity in this capacity has not changed. Something that is to be addressed. I just want to make one. The attention economy is something that we really have to look at because I personally think it's going to accelerate in the next year or two. And I don't think it's going to be legislation. It's us. Whoever said all of us, it's all of us. How we handle it, I don't know the answer. By the way, it's not a US phenomenon. I work for the government of Singapore in the Ministry of Health. It's there. So something that we have to address globally, and it's going to happen fast. We talk about AI, there's lots of benefits, but generative AI and the introduction of avatars, which you're beginning to see, these are chatbots with a face and an image on it. People are building relationships with those avatars. What does this mean in terms of isolation? By the way, we're the most connected time in our entire history, but we're the most isolated in our entire history as a human species. Why am I saying all this? The human species has to adapt every time, and we're adapting at a pace we were not designed to do. So we got some issues to deal with, but I will stop.
Okay. Okay. All right. Listening to all of you got me depressed.
I always do that.
And the whole meaning of this session is transformative solution. Maybe not transformative, at least solutions. So the next round, I'd like to each one of you say, what would you want to do in your domain? What do we need to do to change? And you know, Anita, you talk about a national mission. I say we need a national plan, right? I said earlier this morning in my remarks as president, I say, our medical research needs a strategic coordinated plan together. Sounds like this is exactly what we need, right? Every segment is doing their own thing, trying to survive, do the best we can, and missing the whole picture altogether. So why don't we start with Daniel? What are your thoughts?
Yeah, well, one of my dreams, one of our visions, if you will, is working in collaboration versus in disparate. We have to come together. You know, it's that African proverb: if you want to go fast, go alone. If you want to go far, go together. I would construct this as a quilt. And if you think about a quilt, there's all these different patches. Think about those patches being all of us that do this work in terms of in health, mental health, and then there's one thread that goes through it. An example of that would be 988 with Reimagine. We have an initiative within 988 that we started as 988 was launching called Reimagine Crisis Response. And we brought together over 54 different partners that are a part of that quilt to work with us on reimagining crisis response. In the 2 years since 988 has been here, we've had over 10,000 calls. I'll give you a lived experience example, and you gave me the floor where you said, tell a little bit about yourself and CEO. Those three letters don't mean anything to me. What means something to me is being a parent, being an uncle, being a son. And as a parent, I get calls very frequently. I got a call from a dad that was at an airport on Sunday about to leave for a meeting that he had to go to, and he was desperate. And I need your help. His wife was about to call 911. Their daughter was having a crisis. She was about to call 911 because he had been a part of what we call Ask the Expert event that we had, a webinar. He called me and said, help. We called, and he called 988. His daughter stayed on that call with the certified crisis counselor for an hour and circumvented what could have been a different outcome. That's the reality, and that's what I would like to see in terms of us working together. The other part of it is what Secretary Sebelius said, parity. The administration just really reduced the loopholes. But you know what? We have to inspect what we expect. So I would love to see us be more aggressive in terms of what we know needs to happen. Because right now we have people that are going out of network 3.5 times more frequently because they can't get service. And then when they can get the service, they're having to pay out of pocket. And once they are finished with what they can do, when they exhaust their funding, they stop treatment. Right. So I would like to see the work on that as well. And the other thing that I would say is that there is a tsunami of trauma that was created during COVID with our young people. And if we don't step up to that, then shame on us from the standpoint of what we can do. We did a survey of teens between the ages of, we say teens, but starting at 12 to 17, and they all reported that 1 in 6 experience negative emotions all the time, and 1 in 4 have been diagnosed with a mental health condition. 48% of those teens will talk with parents or a trusted adult about mental health, but they do not start the conversation because of stigma. So we've got to also address that stigma. So this right here that you're doing today helps with that, and we need to keep these conversations going.
Right. But your point is collaboration. That's a key area.
My whole thing is collaboration, and the last thing I'll say is that when COVID started, myself and a colleague decided that we would convene a group of CEOs in the mental health space on a Saturday, and we started that as a huddle. We now have 15 of those CEOs that have been with us since the start of COVID, and we meet every 2 weeks to look at what can we do to change the outcome. So we are constructing that quilt, and now it's called the CEO Alliance.
Got it. But Daniel, I can't help but thinking about those who are not CEOs, those who don't have access easily, the marginalized population. I think earlier we talked about structural racism. How do you actually make sure that your services and all those collaborations are available to everyone?
Thank you. I don't know if you play golf, but you just teed that ball up for me.
I play very poorly, but you know I play with it.
Yeah, we work with, we say nothing about you without you, and you're not alone. So we have to go to where the community is. So we are going to HBCUs, historically black colleges and universities. We're working with the Divine Nine. The Divine Nine represents black and African American sororities and fraternities, and there's 9 of them, and working with all of them. And we have MOUs with several of them to actually do work. And some of them are actually doing work on campuses, major campuses. One of those was, I was at a faith-based initiative and just heard about a work that's being done with a sorority called Delta Sigma Theta at Georgia Tech. And they're doing some incredible work there as a result of a grant that we gave them through that work. So we're trying to get the word out and go to where the people are from the standpoint of in disparate communities, and make sure that they understand who we are, what we do, and the services we provide. And the fact that we need to reduce the stigma and start talking about from the neck up instead of just the neck down. And the other thing from that standpoint is we will talk about diabetes, we will talk about high blood pressure, we need to talk about mental health in the same vein. And so that's another part of the narrative that we're trying to spread.
So, Anne, I think you certainly make a really compelling case that behavioral health workforce is much broader. I even think about in high schools and in schools, the counselors and people who need it to be part of this whole thing, right? So talk to us about how we can make sure that more people enter the field, make sure they're appropriately compensated and supported, and then we have the spectrum of skill set, including, as been said, the use of digital technology, you name it.
Yes, thank you. So in terms of compensation, I mean, there's no getting around the fact that unfortunately we need to increase compensation for all disciplines, all levels of training in the mental health workforce. In my county, I looked this up before coming here, somebody had said it and I didn't believe it, but it's true. In San Diego County, the average wage for a fast food worker is higher than the average wage for a community mental health worker. And that is demoralizing. I mean, I'm not talking about licensed providers, but I am talking about the frontline workers. These are workers that have great responsibility in taking care of kids in particular. My world is kids, so I think in that world, these are people who are helping kids learn to manage conflicts. They're helping kids to learn how to regulate their emotions. These are the frontline people, and their wages are lower than fast food workers. That's a tragedy, in my opinion. We know that burnout is a huge problem in terms of retaining those that are already invested in training. Burnout rates for mental health positions are as high as 30 to 50%, by some estimates even higher. That's compared to about 10% annually in other professions. That's a huge discrepancy there. We also know that we need to invest more in training. Educational costs are high in graduate school to become a professional, but I think the part that sometimes gets lost and where we lose some people in the pipeline is there are actually significant costs after graduation. So across all the disciplines, social work, counseling, psychology, etc., students need to, even once they get their degree, so they've already invested in graduate school, they need to get supervised hours of practice in the community and pass exams and so forth to become licensed. In that period of time, it can be very expensive, and it's expensive for organizations, for nonprofit clinics, for example, in communities. They want to bring those people in, but they're not supported for the costs of supervision. CMS, it pays for MD residents and interns to provide care, but not for non-physicians. So there's a big gap there in that postgraduate training that we need to invest in for the workforce. It's a major limiting factor. Agencies can only have a few trainees because they just don't have the resources to provide the supervision. This theme of collaboration and quilt making, I love it, is so important too in terms of your question about how do we inspire a new generation of mental health workers? How do we, your theme of your meeting about bridging science, practice, and policy. How do we bring in providers who want to partner with researchers, who want to partner with advocates and those with lived experience? Dr. Wells mentioned these models of research practice partnerships in communities, and there are some amazing examples as he highlighted, but that's more rare than I think many of us would hope. Historically, in mental health in particular, the silos between those who are doing the research and those who are delivering care, never the twain shall meet often. And we have exceptions, thankfully, but too often there's just no cross-communication. And in fact, there's some antagonism. And we need to break down those barriers The examples were so great from Dr. Wells and others who are doing this work, but it needs to happen so much earlier. Kids in high school need to be motivated, even if they don't want to become researchers. Okay, that's fine, but we need for them to be the translators of research to practice. We need for them to be the bridge builders to really break down these silos that have been created and are being reinforced sometimes, unfortunately. So
thank you very much.
Thank you.
Thank you. So Anita, you talk about a national mission, right? Is it time? How do we do this?
Yes, it's time. And I really think stigma is part of the core of the problem historically. But I think, we talk sometimes in my agency about, remembering days past when we wouldn't be in the dialogue at all of medicine or sort of some of the talks, some of the, the conversation that would happen there. And now it feels like progressively we're in the room and at the table. So yes, I think now is the time. I do think we've had a problem, as I said before, with creating a national vision We've been so accustomed for years, generations, or decades at least, of going through incremental advancements, and much of which is the state. One thing you have to understand, as Secretary Sebelius mentioned, the understanding, without all the gory details, understanding a little bit about public mental health financing is really important, because the states have a key role that's not the same for health provision. It's different because of the association with Medicaid funding and the way the keen role that Medicaid plays in shaping what types of services are delivered, particularly for those at the part of the spectrum that have the more serious mental illnesses. And so that's really important. And this notion of a common vision is something I don't believe we've had. Over years, you've seen this state that chases after forming more assertive community treatment, the state that focuses on homelessness, and so they're working on supported housing, housing first models, or whatever they're working on that year. This state that's identified children's services as a problem. So it's like, this is part of how the fragmentation has happened over years and years. And this notion that I love so much about the CCBHC program is it really does provide a common vision that has, again, as we saw and we're seeing in New York as a great example of that. It has access requirements. You have to be seen from the time of first call within 10 days. That's a standard for accreditation purposes. It has crisis receiving services as a required component of it. And so that means for individuals that identify as being in crisis, you're to be seen immediately, basically within several hours. It has standards, quality standards, once you're in the box of treatment. My friend Arthur Evans at American Psychological calls that the black box of treatment. Once you're there, it has quality standards. It doesn't say you have to offer this particular type of therapeutic intervention for that, but it does say you have to have a cadre of therapists. You have to provide treatment planning that's coordinated across. You have to provide continuity of care. There's a number of different requirements. I won't bore you with the details of that. It also requires, by the way, interestingly enough, service to veterans, which is interesting because we prefer, of course, our veterans to be seen at a VA, but a lot of our veterans prefer not to be seen at a VA or live far enough away that it's not accessible for them to receive ongoing care as a part of the VA. So that once you're in that box of treatment, it has a number of different of those kinds of requirements. It also has a set of, I call them recovery support services. And so for those who need it, who again typically are more at the more severe end of the spectrum, it has recovery support services that are required. So supported housing, for instance, and supported employment services for those who are seeking that in the umbrella of psychosocial rehabilitation services. So all those parts are there in that design of CCBHCs. It's not perfect, but all those parts are there. Proactive outreach is a component of the CCBHC services. So if an individual gets into a point where they feel like they don't need services or they don't want to engage in services anymore, the CCBHC model goes after them and says, look, George, it looks like it's been a while since you've come into treatment. This is how you can get back in, or what we'd like to do. Anyway, it's not a perfect system, but it is a design that creates a national standard. It also has, in 10, now 20 states, the kind of payment model that Dr. Sullivan also talks about. So not all CCBHCs have that cost-based payment, but many do, and that's increasingly of interest to states. A lot of states are resistant to that because it does cost more, but it really makes the services much more accessible. One of my favorite quotes is from Elko County, Nevada, a services system that became a CCBHC in the cost-based payment arrangement with CMS, our partners over at CMS. And the woman that was in charge of clinical services there said, because of the CCBHC cost-based payment, we can pay our providers. We're not restricted to providing services only based on what we can afford. We can provide services based on what our people really need to have. And ideally, of course, that would be with a needs assessment and based on community needs, but also based on what the market value is of hiring an LCSW, let's just say, to use that as an example. So they were able to hire and actually recruit from out of state therapists because of the cost-based payment. So those are important features that are design elements. And so that's one of the ways I think of SAMHSA as having a role, is as a designer for startups, so to speak. Ideally, our grant money would be used for initiation of services, conforming to the requirements of the CCBHC model, say, for instance, in that case, and then have a sustainment plan that involves working on once the services have been acquired. It doesn't always work that way, but that's sort of part of my vision of how that would work is to have our funds used to help with capital funds to start up a particular service in the case of CCBHCs. So I think that's really important. One other thing I have to say is that, when we were born, SAMHSA is a 32-year-old agency, we were carved out of NIMH because the federal government at the time was sorting out what role the federal government should have, not wanting to supplant the role that the states have, which has traditionally been very important, primarily really because of their role in institutional support of institutions. However, one thing that's really important about that role of the states is realizing that exists and is really an important kind of feature. So states are important. I guess I'll just end with that. States are important in the funding. I just
we
want
know
to say
that.
From a design element, yeah. But there are things the federal government can do short of that, and I do believe one of our opportunities at SAMHSA is this design concept, putting that out to the extent we can for both the CCBHCs, to use that as an example, as well as the 988 and related crisis services, the spectrum of services.
Thank you. And perfect segue to Congressman Beyer, right? How can Congress help us move these issues forward?
Well, I feel like I'm going to go the opposite way. I love your common vision. So let me do the opposite and give you a bunch of pieces. First, 988, which is, I think, just a wonderful success. The statistics I've seen recently are 7 million calls are expected this year, which is more than double what we had before 988. The 13 seconds is the latest I've heard. You're down from a minute and a half, 2 minutes to respond. The call centers, we spent an afternoon at the Northern Virginia Lifeline Center out in Oakton a couple of years ago, and they just talked about the calls that don't get answered because there just weren't enough volunteers, enough trained people. So that's a wonderful thing, except that we need to tell a lot more people about it. We need to tell the whole world about it so that if you're in Switzerland or Sudan, you can call 988. We do have a wonderful bill on the Hill called the Campaign on Suicide Prevention that is specifically just to educate the public about 988 and about how you talk to your friends, family, coworkers about suicide, because it's different from when I was a kid where you didn't ever talk about it because you might give them the idea that they might do it. We have a wonderful bill called the Barriers to Suicide Awareness, which is literally giving money to state and local governments to remove or protect those physical aids, for example, the nets on the bridges. The most best example. Yep. Or the telephone pole that has been used repeatedly to run into. And local police all know where people can die by suicide and address that. Artificial intelligence is a huge piece. You mentioned veterans. The Veterans Affairs has stood up, I think, the best artificial intelligence research into why people, or what are the warning signs about somebody who is at risk. The two throwaway factoids are that someone who dies by suicide, 50% will have had an emergency room visit in the previous 6 months. Greater percentage than that will have had a healthcare visit in the previous 90 days. If we can find 18 other of those things and put it together, all of a sudden deep learning, machine learning can work to help us tell that somebody's at risk that might not be giving all their stuff away. Same with using AI to train the Lifeline counselors, which is working really well. So you don't have to go through weekend after weekend after weekend. You can actually have those models, using large language models, teach people to be Lifeline counselors much more quickly. And then diagnosis. But then peer-to-peer counseling, Dr. Dzau meant. We had John Hickenlooper, the champion on the House side or the Senate side. We got a bunch of House people coming together, trying to empower young people to help each other. Mentioning my son, one of the big things is changing the state laws. Virginia law, for example, is you have to be in imminent danger to yourself or others that day. If you threatened to kill somebody yesterday, it doesn't count. So I'm a big fan of the Treatment Advocacy Center, the whole black robe effect and mandated treatment. That's going to have to be handled probably one state at a time, but it's really important to do. And then more research. Bristol Myers Squibb's just recently announced the first new schizophrenia drug in 30 years. 30 years with you're still people on Seroquel and things like that. And then finally, let me just put this on in my congressional hat on. President Biden and Kevin McCarthy negotiated the Fiscal Responsibility Act about 16 months ago, which limits the federal budget to a 1% increase for each of the next 10 years. So that's not inflation adjusted. So we're looking at a fiscal place where we want a lot more money and there's not going to be any money there. And that's before the current campaign promises.
Thank you. So I'm going to ask Ranga and Kathleen Sebelius to kind of put it all together to say what are the things we need going forward. Maybe we'll start with Ranga first, because I certainly want Secretary Sebelius to tell us about this 5 big ideas that is developed at Aspen. So, we heard about also technology and drugs and
So maybe I'll just try to take a look at the entire day and get some perspective and thoughts about going forward. First, I think the research is slowly beginning to pay off. So I do think the progress is happening on building better treatments, getting better evidence for therapy. The gap is the second gap that you talked about, translating that into the real world. That is a big gap, and we have to figure out ways to address it. And I think the third, which Richard Frank alluded to and I think said, some difficult challenges that we have to face head on, and which is not about money. One of the things that we really don't think so much about it is how we spend the money matters a lot. And I can give you examples of what we have tried to do within the constraints of how Medicaid works. Okay? But the key here is we have optimized each component to the point where that component does well, but the big one does much poorly. So the estimate from mental illness effect on medical cost by the Milliman report is about $400 billion a year. That's a lot of money. Okay? If you were to rethink of how to do it, you should be able to do almost everything we're talking about. Even take 20% of it, that's a fair amount. That's something we should think about. Some of it is insurance, because the way it's optimized in insurance. Some of it is transaction-based care. So we are doing experiments within certain states, and I'm not going to get into details, but the essence of it comes to what New York State was talking about. We forget about housing. It's not just a determinant, it's an effect of the illness, and it's a cycle. You have to solve that cycle, particularly for severe mental illness. It isn't going to go, and it costs you a lot more by not solving it. That's something that we can do something about. Second, in the context of patients coming in to a medical center, when we're having to rush, we were screening everybody when they walk in on day one. If you screen them, 25 to 30% have either depression, substance use, or alcohol. What we do then is start a treatment plan on day one. It cuts the length of stay. That length of stay cut pays for the whole thing and more. So it's possible to redo what our current system has artificially created problems that we can solve on the ground. But if you're a CEO or a CFO, that's not what you want to do, because you'd rather not think through all these things and just think how to quickly, because you have issues around labor, workforce shortage, workforce burnout in healthcare is a real problem. We're asking fewer people to do more things. Not going to work. So I think there is a need to rethink and redesign. And we cannot think of this as a medical issue. We cannot think of this as a health issue. We cannot think of this as a social issue. It is all of it together. If we do it separately, we can build better treatments, we can have more therapists. 10 years from now, it'll be the same as it is today. It's not going to solve it. To do it, I think Richard was bringing up, and you were talking about housing. Some of it is arcane to me about what rules and all those. But if you have to have it, you've got to think of how does housing fit right up front in managing this? How does community health systems fit? Because that's a different kind of service that transaction care doesn't do. How do I build it all together? It's a reframing, restructuring, reassessing, and you have to do it at a local level, unfortunately. I'm involved in 2 such projects at a local level, and I can tell you within a year, we are seeing big impacts without spending more money. I get the point. There is no more money to spend. But we have to reconfigure, which means think through all the barriers. Federal level, there's plenty. Insurance level, there's plenty. State and regulatory and training level, there is plenty. Each of those things have to be dealt with because we don't have the money to keep throwing more money at it. And by the way, I don't think it'll work. I really think we have to rethink the entire thing, and probably NAM has to pull together a group to say how to do it, probably with SAMHSA, because I think this problem is clear. And you've seen the bits of the solution all day long. What you're not talking about it is how do we put it together without increasing the cost. By the way, if you look total cost of care and you deal with mental health, your TCOC should go down.
What you're saying is, assuming there's sufficient funding, the fragmentation and efficiency and the whole system, right, is some of the problem. There's a lot more waste and not efficiency. But I'd like to hear from Secretary Sebelius. She co-chairs with Bill Frist, Senator Frist, the Aspen's Health Strategy Group. And we had the meeting this summer, which we spent quite a bit of time thinking through this issue, and came up, in fact, with some new ideas. So if I may ask you, Kathleen, to share those ideas with us.
Well, first of all, I want to recognize that I'm the reporter here. These are not my ideas, and I want to shout out the fact that Alan Weil is here from Health Affairs, who is our scribe and convener and editor. Ruth Katz is here. Ruth is the executive director of the Health, Medicine, and Society division of the Aspen Institute, and she really convenes this. Ann Gardner was one of our experts, and we rely on experts to come and teach us about these. And Dr. Dzau is a member of the group, so this is hardly a unique presentation. But one of the things that we've been able to do, sort of focus on one idea a year and try to get experts who do deep dives into the area. And our membership group is some healthcare providers, CEOs, policymakers, economists, people who are coming to health issues from a variety of lenses, and not try to be competitive with Congress. I mean, the goal is not to endorse bills that are already in play, but what are some things that could be implemented potentially to look at this? So our focus this year was really adolescent and child crisis in mental health. And I would say just a couple of things in terms of framing the issue, that it's got to start with us recognizing it is a crisis. The Surgeon General has called it out, others have called it out, but I think it's a crisis that health providers have to call out, not mental health providers, health providers. This is a crisis that I think we need to deal with, and that the health sector is uniquely positioned to lead that. And you know, our view was that you've got to start with the youngest children. They're really at the tip of the spear, and if you can solve for particularly some of the youngest children at the most risk, you will end up solving for a lot of the population. Second kind of theme that emerged is just we have to get to some real definition and then promotion of evidence-based strategies, evidence-based standards used at the federal, state, and local level. And I would say SAMHSA has done a brilliant job in a lot of this, but I'm becoming more and more a believer that with the money needs to follow a little bit more of a mandate to follow some evidence-based strategies. We found out, with the Affordable Care Act that money is a big incentive. And when you said to people, you actually can qualify for insurance benefits if you have a defined health plan that meets these essential health benefits. They've never been defined before in specific terms. Mental health, I think, needs that same set of strategies. What are the definitions of an adequate mental health program. What does a screening look like? What does an intervention look like? Clearly, family and community-based healing tools are important, and the recognition that this has to be much broader than the health community with schools and community groups. So the 5 ideas that we talked about are, first, we have to start with prioritizing prevention. That both in Anne's terms, she was a brilliant educator in a lot of this, but primary prevention, where you screen at the earliest possible level. You look for signs of trauma. You try to intervene as early as possible. And then secondary prevention, which is to intervene once some kind of crisis situation has occurred or some kind of trauma has occurred, but try to prevent it from escalating further. Try to, rather than waiting until somebody ends up in an emergency room, in a jail, in a crisis center, in a the earlier the intervention can happen and the more the focus is on prevention is important. Secondly, access, and we've talked about that in all sorts of ways, is important, and particularly access to children who are transportation dependent, who are locked into situations where often they're at very high risk, but they don't have any way to get out of that situation. So looking at ways to improve that access, and again, that's a lot of place-based services. That's services in school. We know that children are likely to be in schools and daycare centers, so how to equip the schools. I mean, frankly, and I don't know about the Congressman, you've talked a lot about, suicide and gun prevention. The amount of money we have spent putting armed officers in schools as opposed to nurses, counselors, librarians who have mental health training, people who can actually spot early intervention. I would say there's money there, and I know where to get some of it. It could actually be spent on, if we want to keep kids safe and healthy, that's a really good way to do it. But making sure that we have access, that rural communities, underserved communities, tribal communities, high quality and evidence-based treatment. Over and over and over again, it's demonstrated that that is not the protocol. That, and again, that's not terribly different than physical medicine, where the known protocol is not followed on a regular basis by too many providers. And again, money from the federal government manages to solve that. If you say to a primary care doc, you get additional resources if you do these preventive measures, if you screen for cancer, if your patients have we should be doing the same thing for mental health. Those kinds of pediatricians. I'm the grandparent now of 5 lovely grandchildren, but 2 relatively new ones. And I can tell you, my daughter-in-law my daughter-in-law and my son are trying to follow all the protocol about, foods and screen time and everything else. But they're not, I asked them the other day when I was putting together some notes for this, what does your pediatrician talk to you about signs that your kid may be having trouble? What are you told to look out for? I mean, they know growth measures, right? You know what a toddler should do at age 1, and if they're not walking appropriately. Those kinds of screenings should be widely available to parents who are trying to do their best, but they don't know. And particularly, I know home visitation can be very successful, but it isn't nearly employed often enough. So having high quality standards that are implemented, government support that is driven through the states, because a lot of the SAMHSA block grants and it come to the state level, but down to the community and local level. And again, I'm, as a former governor and legislator, I didn't like when the federal government told us what to do. But frankly, you need to tell states what to do. Just saying, it works. If the money is tied to having programs on the local level, putting a table together at the local level where service providers have to sit down with it happens. And if it's not told, it will happen sporadically and in some places. But so driving that money to the state and local level with government support. And then this is the most interesting, and I can't wait till I'm giving you sort of the Cliff's notes of an early preview. The document isn't ready yet, it isn't finalized, but we had probably the most robust and interesting discussion about technology and about both, warning signs about social media and screen time and issues that really may affect negatively, particularly young people's mental health, adults' mental health. We're all in this, what did you call it, the attention economy. On the other hand, technology can be hugely impactful in a beneficial way. Telehealth gives access to all kinds of people for mental health services that they could not possibly have otherwise. But we talked about needing a clearinghouse for digital therapy, somebody who really is looking at, whether you call it a STAR program or a good housekeeping stamp of approval. How do people discern what works and what doesn't work, what may be beneficial and what may be harmful? Standards that regulators have to pay much more attention in, and all due deference to my congressional colleague here at my left. I do think that we can't keep it. Technology is the only industry in this country that has no regulatory rules at all. None. Zero. Zip. Some of the richest people in the country are making rules for the rest of us, and people are backing away from saying, oh, we can't get there, we can't stop it. I just beg you, please, dive in, man, because I think it leaves people trying to figure out this very complicated world on their own. And 20 years is enough. 25 years is too much. I think we really need to tackle it. So those are sort of the 5 areas that we looked at, and all can be probably implemented at a local level fairly quickly, encouraged at a state level, and hopefully can be embraced at a federal level. And our report will be probably ready, finalized toward the end of the year, early next year, and be widely available on the Aspen Institute website. But we hope it just adds a little bit to the conversation. It's not specific legislation. It doesn't have to have, much of this doesn't really require new funding. It is actually redirection of some of the funding that's out there, and hopefully can add to this robust conversation. So again, thank you, Dr. Dzau, for focusing the Academy on this very important topic.
Well, listen, we've had a long but extremely productive day. And I would say this last panel exemplifies the passion, commitment, and people finding solutions together. I heard a series of really good suggestions, how we can work together towards this. So I do want to end this meeting on a high note, which is that you heard 6 experts and all of you wanting to do better than where we are today. And in fact, many panelists brought so many different ideas. And this panel, thank you very much, has been able to bring some of the thinking together. Particularly, I believe that the last ideas that put forward by Secretary Sebelius, I think, at least give us a framework, a roadmap, if you will, towards the next few steps. So we had a long day, and we won't take any Q&A. There's a reception out there, and I thank you very much for really attending all day. Thank you.